Now we will move to the second session. It's a pleasure to present Dr. Suhail Al-Shamari. He is the father of neurology in Kuwait and the father of MS, the first Kuwaiti doctor he got fellowship from Canada. Dr. Suhail Al-Shamari is associated professor at of neurology in Kuwait University. He is consultant and the head of neurology at Mubarak Al-Kabir Hospital. He is director of your neuroimmunology service. Please welcome Dr. Suhail.
Thank you for the invitation. The excellent preparation for this conference. Welcome. I'm going to talk today about neuromyelitis optic spectrum syndrome and what we abbreviated as an NMOSD, which is I'm going to stick to it. And this is my overview. What I will concentrate more on the advances in treatment just because of the time limitation. Now, in history, since the description of NMO in the late 18th century by Divix, actually we went through about a century without any development. And it was felt at that time that is a monophasic disease with optic neuritis and myelitis. However, I think that in this milestone, the most important thing is over here in 2004, when a biological marker was discovered by the Mayo Clinic group, and it was called NMOIgG, which is directed against a water channel in the brain and the spinal cord, which is covalent 4. And the other, I think, important milestone, which we have to remember, is in 2015, when the diagnostic criteria was further reviewed, and the term NMO spectrum disease was considered. And this is actually to take into account form of frusty of NMO, because there are actually isolated optic neuritis and isolated myelitis, and there are other common features. And then you see, as you see over here, we have actually the MOG IgG has come into view, which is quite an important advancement. So why it is why it is so easy to diagnose NMOSD? It's just because of the typical presentation, including optic neuritis and myelitis with a longitudinally extensive lesion, as well as because of the restricted clinical features. Usually a cranial MRI is normal, oligoclonal bands are negative in the CSF, and the characteristic relapsing course. And of course now we have a specific biomarker, covalent IgG. Now, why it is not so easy to diagnose NMOSD? It's just because you see some variation and heterogeneity in the presentation. It could be an isolated cause syndrome, and it could be also quite variable presentations clinically, and you may not have actually LATM, and the brain may be also affected, as well as about 30% of people with NMOSD, they have negative serology and false positive sometimes some assays, and as well as the atypical core and comorbidities quite common with this disorder, and they may have a dual pathology. Now, this is showing you the NMOSD 2015 clinical criteria, which actually, as you see, based on the biological marker and no competing or alternative diagnosis, it is divided into serology, seropositive and seronegative. With a seronegative, you will need at least 2 core manifestations, at least one of them optic neuritis, myelitis, or area postrema syndrome. And here the aquaporin 4 is negative, but we need really more stringent imaging criteria. Now it seems we have untangled COAS, and we are going into a land of order. So there is a lot of actually interacting conditions as well as clinical manifestations. But this has come to an order, and now we have actually the aquaporin IgG syndrome with you see a range of severity, as well as in addition to the core manifestations, we have actually other CNS involvement, that's the brainstem, the circumventricular organ, and supratentorially as well. Very curiously, sometimes you have also extracranial involvement, and there are a direct involvement, which you see them with the co-symptomology, and indirect, such as hydrocephalus. Then it came into view and quite evolving, the MOG syndrome, and we have aquaporin 4 syndrome with paraneoplasia, which it seems affects older people and can be more intractable. Comorbidity, whether it is neurological or non-neurological, is very well recognized. And there are actually also mimickers we have to exclude. Now we have a typical myelitis, and we have a typical optic neuritis as well, atypical forms. In the typical myelitis, we have actually aquaporin 4 positive serology, while in the atypical, you see you have the short lesions of myelitis in 15% of cases, mild, asymptomatic, and they are seronegative, and they could be MOG positive. Again, unilateral or sequential typical optic neuritis. It is more posterior in NMOSD, affecting the chiasm, and it's severe with positive serology. Otherwise, in the atypical form, mild anterior and seronegative, or actually there is a MOG positive serology. Now I'm just showing you here the LATM lesions, and please concentrate in the right panel. That's the MOG phenotype, and in the left it is the aquaporin 4 phenotype, and you see a swollen you see in the center of the spinal cord, and I'm showing you here actually and posterior lesion in aquaporin 4 IgG in the left side image, and anteriorly quite clear. You see it in the left in MOG, in the right in MOG. And here I'm just showing you actually a central, you see equivalent for pathology in the axial cut. Always examine the axial cuts. And you have what is called a shaped lesion in MOG positive. Now, MOG-associated disorder may not look at all like NMOSD, as it may present with ADEM, particularly in kids, and with recurrent optic neuritis, also a cortical encephalitis with seizures and encephalopathy. And actually, you see what is called the flames in the over here. And so there are other features which were also shown here, like leukoencephalopathy, subtentorial involvement, and very rarely at all you have features of MS. Now, how do you distinguish MOG from equivalent 4 and MS? Just going this busy slide, but you see, just watch the red, colored indicators there. So there's some epidemiological demographic changes. Female is actually are more affected than MS, but that's not true in MOG. White people are affected more with MS, but actually non-white are more affected with equivalent 4. Still it is uncertain with MOG, and it's quite clear now autoimmunity is quite common with equivalent 4. Now, we talked about optic neuritis and myelitis, and you see there is an overlap between MOG and equivalent 4, and the lesions are really short in both in MS. Area postrema is a quite characteristic of equivalent 4, seen in about 20% of the patient, almost never seen in MS. Cerebral symptoms more common in MS, and very characteristic relapsing course in equivalent 4, and severe attacks. Also, difficulty you see with recovery from a relapse in equivalent 4, often poor. The other important point to keep in mind is where the progressive course. If you see a progressive course, this is really a big red flag that this is not equivalent 4 NMOSD. And I show you here just the lesions actually where, the posterior medulla, where it's, the arrow is showing, that's area postrema lesion. And I'm showing unusual lesions as well. As you see in P, there is a cavitation in the pyramidal or corticospinal pathways, and we have periependymal lesions, as you see over here around the 4th ventricle, and also in the diencephalon in the extreme right photograph. Now I'll just go quite quickly in this because we talked about it. You see now extra to the core manifestation, brainstem can be involved, and area postrema can cause intractable nausea, vomiting, and hiccups. There are other brainstem signs, and the diencephalon is affected actually, and you could have a narcolepsy or an anorexia, and other focal and diffuse symptomology, and as we said, myositis can be a feature. And this is just to tell you that you see a brainstem in about a third of patients in equivalent 4 patients. And this is just a study where to document myopathy associated with equivalent 4. And here, just to show you that we have a plethora of comorbid illnesses, more than 20 different autoimmune diseases, SLE, Sjogren's syndrome, as well as you see it could be associated with limbic encephalitis, NMD encephalitis. So in the sand, you see how this is entangled, and it should be unentangled. Cancer come also in the view, as well rare syndrome like the ACARD Cavitary syndrome and seen in children. Now, this is just to tell you in 691, patients with anti-NMDA encephalitis, 23 indeed, they have overlapping with demyelinating diseases. If you see in the over there, it is bi-directional way. Now, mimics inflammatory MS, sarcoid, GFAP, lupus, vasculitis, cancer, paraneoplasia, particularly with the CRMP5 autoantibody, B12 deficiency, and other genetic disorders. Now, why it is, you see, why it is important actually not to miss the diagnosis of NMOSD. You should look for objective findings. Don't go for serology only, and look for red flags. Remember that we have to do a cell-based assays, which is actually sensitivity up to 80% and more than 90% specificity. The MRI will tell you we are dealing with a red flag, and always inspect axial images. Now the CSF shows oligoclonal bands, that's a red flag. And if it is a progressive course, as I said earlier, this is a huge red flag. And consider other pathologies when there are pathognomonic radiological or clinical findings. And the mimics, most important to concentrate whether it is really MS or it is NMO or aquaporin 4 positive versus MOG phenotype. Now, this is to show you just the pathophysiology. And if you see at the extreme left over there, you have naive T cells, which they become actually intolerant. And then there is a bias of T cells to Th17 pro-inflammatory phenotype, which going actually to stimulate the B cells. And after coupling with the aquaporin antigen, and then you see we have actually interleukin-6 comes into action, and prime P cells into plasmablasts who are going to secrete the autoantibody aquaporin 4, which is actually IgG1, and then it goes and into the circulation, and actually it gets through the blood-brain barrier and the foot end or processes of astrocyte, and this is an astropathy. And you see there is supramolecular aggregates, and if you see here, we'll talk about it later, about different immunotherapies, whether, there is experimental work in tolerance induction, immunosuppression, which they are always off-label, and then we have the monoclonal antibodies, CD19 and 20, which we will talk about it in more detail later on. Now, we have central peripheral tolerance defects, and there is the requirements for aquaporin somatic mutation for its actually production, and we have it arises peripherally from a pool of autoreactive B cells. So that's what I just talked about, and I come now to treatment. And the treatment actually has been quite scarce in the past, and most of these patients before the aquaporin 4 discovery were treated as MS. Mandler 98 showed that azathioprine is effective, while Weinschecker from the Mayo Clinic in 99 showed the first controlled sham. Plasmapheresis is effective in 41% of people with idiopathic severe demyelinating diseases, including NMO and MS, ADEM, and others. And in 05, he showed the efficacy of rituximab. So how do you treat an acute attack? An acute attack is very important here in NMOSD because it is the precursor of disability. It is not really the progression like in MS, which causes disability. So early initiation of IV-MP is very MP methylprednisolone in the classical way, very important. And if you use it actually within 4 days, the prognosis is excellent. You see, if you go beyond 7 days, we are in a murky zone and the patient may not recover. Also, it has shown that axonal loss will be less actually after steroids. You know, there is also, if you see the algorithm there, you could start in severe cases a plasma exchange right away, especially if the patient previously experienced a good recovery with the plasma exchange. You could start with IV-MP and escalate to the Plex. Now, good news, actually, in the last 2 years, we have 4 phase 3 trials for the first time in NMO or NMOSD disease, and 3 drugs were approved by the FDA, the eculizumab, ineplizumab, and satralizumab, which I'll discuss them now, just their key features. A PREVENT study, the eculizumab, which is an anti-complement, C5IG1, which actually they included only aquaporin 4 patients and EDSS of 7 or less, and background immunosuppression was not allowed, was actually allowed in 76% of patients. And there was, I could say because of the limitation of time, that there is very significant reduction of risk of relapse, but there was no effect on EDSS, quality of life, and there was high rate of upper respiratory tract infection. Here, since it is anti-complement, you have to vaccinate the patient against meningitis, meningococcal meningitis. In the momentum, ineplizumab is anti-CD19 humanized IG1, and here in this study, aquaporin 4 positive and negative were included, although the bulk was positive, and there is no IST in this actually, or immunosuppression was allowed. Again, a very powerful effect, and it seems the number of patients in ineplizumab were less progressing in ODSS. Then we have the 2 study, the Acurus SKY, which is the combination therapy with immunosuppression, and the Acurus STAR with actually only monotherapy of satralizumab, which is anti-leukin 6 actually receptor. So it is like tocilizumab, which is also unavailable. Both of them, they were effective. There are no effect in AD and relapse rate actually reduction. There is no effect in EDSS at 24 weeks, and there is no serious side effects actually were reported. And now what did the trials tell us? That all the treatments are highly effective, and it is really important when you know actually that with the genetic antibody, you could tailor more effective treatment, and the effect is mainly in aquaporin positive, unfortunately not in the negative. The evidence is not quite. So what did the trials not tell us? That modification severity of attack, you see, you reduce attack severity. For example, in ineplizumab, using OASIS scoring system, apparent reduction in attack severity and enhanced recovery. Comparative study and head-to-head studies are not available. We are not sure about the duration of effect, the safety of treatment, and the long-term benefit. Identification of optimal responses are important, and again, you see here, sometimes maybe just, you see concomitant treatment can affect outcome, as you see on the right side panel, where you see on the lower panel, there is actually the placebo are doing better compared to, you know, the active treatment. And there are different attack definitions, the different duration of randomized phase. These are all actually confounding factors. So what do you do with the new drugs? Stick to the existing treatment with drugs. If the patient in treatment, he could be, even if he fails, he could go to another treatment. Otherwise, he could go to the new drugs. And in new patients, you could stick also to the new drugs. And in many countries, actually, these drugs are very expensive and they may not be available. And patients who are stable, of course, you have to continue the treatment. Individualized treatment is coming in the future, and really we don't know what to do with seronegative. And I am not going to discuss actually the off-label treatment. They are well known, the azathioprine and rituximab, and rituximab more effective than azathioprine. Mycophenolate mofetil also is effective, actually reducing relapse rate. It is expensive as well, like rituximab. And tocilizumab also actually has been used in 3 case series, and it showed decrease in annualized relapse rate and EDS score into a study. And also in one prospective study, open label, demonstrated long time to relapse with tocilizumab with actually compared to azathioprine. Here we have data that tocilizumab is really superior to azathioprine. And you see there are 2 patients with MOG IgG, which they were unresponsive. And IVIG is important in MOG, and this is the line of treatment now. And this is actually just an algorithm. And it means, you know, you start with the standard treatment with off-label, and you could move to the new medications depending actually in the class which has been used. And now, important question, and I know I am over time, but this is, I think everybody's asking about this. This is just a 2021 update. And when can we stop immunosuppression in NMOSD? Really, the bottom line, you cannot stop it. And this is seen in this study. And this is going back. Sorry, I'm just ending now my talk. And this is just discontinuation of immunosuppression therapy in this study, which is quite recent in NMOSD. Aquaporin positive patient is not possible. They relapse. So please continue. And this is drugs in development, poramab, bortezomib, and revolizumab. You will hear about it because this is actually going to, and this is the next generation of antibody targeting C5. So like eculizumab, but you see with a prolonged action, so you could prolong the interval between a treatment to actually 8 weeks, and also wait for this FCY receptor anti-CD20, more selective than rituximab, the eplitiximab. And finally, you see there is also a role for refractory patients to receive hematopoietic stem cell transplantation. This is a study from northeastern US. It showed actually remarkable effect with prolonged drug remission with aquaporin for IgG seroconversion to negative. So implications, are we still ethical, to do placebo control? The powering has to be improved, and we need really to enhance endpoints. And there are still some unmet needs. Attacks continue despite all treatment, and we have to identify risk factors before attack occurring, and to allow modification or escalation of therapy. Biomarkers like a GFAP, neurofilaments, covalent 4 will have a role. A treatment of seronegative MOG is still not decided upon. And so the conclusions, first-class evidence for NMOSD therapy, all 3 reduce attack frequency and 2 appear to reduce severity. Still, there is no cure. There are unmet needs, as we talked about, regarding specificity, safety, efficacy, cost, very prohibitive, I should say, in many countries and majority of countries of the world. Long-term efficacy, still we are not sure. New, more sensitive and informative relapse marker like the secretory GFAP and tolerization actually techniques are under study. And I would like to thank you, and I apologize for going over my time. Thank you very much.
Thank you, Dr. Sohail, for this amazing presentation. Actually, this hard topic, and usually we face difficulty for diagnosis this group of patients. Thank you for clarification of important points.